And with that, I would like to now turn it over to Bill Smith, the Executive Director of the National Coalition of STD Directors.
Hello, everyone. I hope you're doing well. Again, this is Bill Smith. I have the great pleasure of being the Executive Director here at the National Coalition of STD Directors. We're a national nonprofit organization that represents state and local health department STD programs across the country and the strong staff working in those health departments that keep our communities healthy and safe. Before we start today, I'm just going to do a very brief intro, but I'd be remiss if I didn't start these brief comments with thanking Stephanie as head of our policy and communications team here at NCSD for putting this together. As some of you may know, and we apologize for any inconvenience it may have caused, we're doing two of this particular theme of the webinar because we had such overwhelming response. So for those of you who were unable to make the first one because of space constraints, we're really profoundly thankful that you prioritized it and come back for the second one. And it created some challenges for Stephanie and my team here in coordinating it, so just a big thanks. So I'm not going to say too much to sort of get things going because I think you're going to be really informed and come to some, I hope, some creative thinking from what you hear today. I can tell you here at NCSD, we think a lot about the sexual health framework and really getting out of the individual silos that many of us find ourselves working in, including us here at NCSD on STDs. But we've strived over the last couple years to create a larger framework for our work. That includes changing our name, and as you can see on that front slide, we've added the tagline, Promoting Sexual Health Through STD Prevention. And more recently and more concretely, we actually held a meeting with several states and national partners from the public and private sectors to talk about what state sexual health plans and frameworks look like at a state level, and trying to advance some of that thinking and understanding that can bring together diverse silos of work to create broader sexual health outcomes across the board. But of course, in the midst of that work, we constantly come back to a key question, which is, okay, so if I'm beginning to understand conceptually what sexual health is, and that is working across silos, how do we measure those outcomes that aren't simply outcomes that show disease has been averted? What do those types of measurements look like? And I think it is a profound question with elusive answers. And I will say that when I first came across the work from the Sexual Health Rankings Project that you're going to hear from today, I had one of those moments where I was like, wow, this is really cool stuff, and it has me thinking in creative ways that I hadn't before. And I hope that you will share some of that when you hear from our speaker today. And again, I just want to thank my team here at NCSD for putting this together, and to our speaker today for the repeat performance. So let me introduce our speaker, who's Martin Downs. Martin is the founder and principal of Variance LLC, a research and communications firm dedicated to promoting sexual health, and it's based in Lebanon, New Hampshire. Martin has over 13 years of experience as a journalist and a public health professional, and he's a graduate of the Master of Public Health program at the Dartmouth Institute for Health Policy and Clinical Practice. So with that, I will stop. Again, thank you all for taking time to join us today, and I'll turn it over to you, Martin.
Thank you, Bill. I really appreciate that introduction. And also thank you to Stephanie for all of the organization and of this webinar. I just want to check, am I coming through clearly?
You are, Martin.
Okay, very, very well. I'm going to be asking you to advance the slides as we go through the presentation. Is that correct as well?
That's correct, yes.
Okay. Well, why don't we go ahead and get started. I'm going to give you an overview of what I'm going to be talking about. If you want to go ahead to the overview slide. I'll give you some background about the project, where it came from, and where I came from, and then what I'm hoping to achieve, and spend a little time on that. Go over in review the results from the first edition of Sexual Health Rankings for the year 2012, which was released at the very end of last year, coming up on about a year ago. And I don't want to spend all of our time on that because all those results are online at our website, sexualhealthrankings.com. I really want to spend the bulk of our time talking about measuring sexual health, the approach that this project takes, and some of the issues involved and questions, really. I'm going to try not to lecture you too much, but really, just talk through some of the things the important things that are involved, and then we'll have Q&A. So, if you want to go ahead to the background, of course, Bill gave me a very nice introduction, and I want to take a minute to reflect and think about last year at this time. Things were moving along with developing this project, but I still really had no idea how it would be received, if anybody would be interested, or if anybody would think it worthwhile or valid. So I'm really very, very pleased that so many of you on the call today, are interested, and thank you for signing up and having me back for this encore talk. If you want to go ahead to the next slide, there I am. Variance LLC is my company. I started it last year in 2012, based in Lebanon, and it was. If you want to skip to my pretty picture slide, that's where I'm talking to you from, in the second story left office there. It's not quite as pretty today, but go on ahead. Variance is an enterprise dedicated to promoting sexual health through pursuing novel investigations, developing innovative information products that hopefully yield valuable insights on sexual health and are valuable to people who want to know about it. And as Bill mentioned, also, I'm a public health person. So before I got into this, before I started this endeavor, I worked at a small nonprofit public health organization here in rural New Hampshire, and I carry those values with me in terms of the approach that I take with this enterprise, and it emphasize positive approaches to sexual health, which is important. I want to focus on not the scary and the dreadful and the dire in sexual health, but rather promoting a positive outlook. If you want to go ahead and skip to the next slide. So Sexual Health Rankings is Variance's inaugural project. And something I neglected to say in my first webinar is that this project is an entirely independent initiative. Somebody had asked me who was funding it. to date, no one is, and it's been entirely self-funded and self-sustained to this point. And that is just something I thought I ought to throw out there because I guess it's relevant. The goals of the project. So why do this? To promote a positive and wellness-focused approach to sexual health, to hopefully help get people comfortable with talking about sexuality, to normalize discussion of sexuality, and to prioritize it, to make it, bring it to the fore, and give it legitimacy and importance in a way that is not crisis-based, about, in a way that's not about freaking out about some horrible thing, plague, or bad consequences of sexual activity. So, including sexual pleasure, which tends to be an elephant in the room often when discussing sex in a public health context. It's a research project, and it has research and public health practice goals as well. I'm very interested in how sexual health is measured at the population level, and I want this project to hopefully improve and expand the kinds of things that are measured at the population level, and understand it better, understand variation in population sexual health. Sexual health rankings focuses on the states, and that's because I think that in the U.S., states are a meaningful geographic unit, political unit. States have, there is variation in how states approach sexual health. So more concretely, and before I move on, actually, I think that doing the second two bullet points there, it has the effect of promoting, by including sexual pleasure and not focusing exclusively on measures of disease and bad outcomes, has the effect of promoting a positive and wellness-focused approach to sexual health, and also has the effect of normalizing discussion of sexuality. It gets it out there, and people become more familiar with hearing about it. So if you want to move on to the next slide. More concretely, the objectives for last year and throughout this year were really focused on constructing this composite index of sexual health. Getting the results, sharing the results on the web through the website, sexualhealthrankings.com, which is a portal for the research results and methods, and a tool for communicating, and then to really get to find out what stakeholders have to say about it, and actually incorporate the feedback into the rankings, into the composite index, to continue to develop and improve it, put it out there, get more feedback, and generate acceptance and buy-in, and hopefully produce something really worthwhile. Next slide, please. This is the timeline of how things went down last year. Around May of 2012, I stopped thinking about doing this and being interested in doing this, and actually began to do it. By September, I felt that I had something worth pursuing for sure, so started Variance. Had a draft of the research paper done by Canadian Thanksgiving in October of 2012. And I realized that the other part of this project, it's not just a research project, it's also a communication project, and it's about engaging many people. So I felt that I couldn't do that alone, and I wanted to partner with someone who was excellent at doing that. So I reached out to Megan Andieu, who is the director and founder of the Center for Sexual Pleasure and Health in Pawtucket, Rhode Island, and suggested that we might work together on it. And she agreed to help put it out there with her organization's support in terms of, and I'll get to that in the next slide. So by around this time last year, we were building the website and got it up on the web just before the end of the year. Next slide, please. So about our partnership, this is kind of showing the roles of each organization. Variance is does the research, is the principal investigator role, project management, production, and the CSPH has provided some really terrific people to help me get it out there and work on it. And Megan also is always on the road with her college sex tour. So she is practically every day up in front of people talking about it, showing it, and also the CSPH folks have helped with developing the web and social media engagement approach. So next slide, please. I want to acknowledge, I mentioned Megan. I also wanted to acknowledge Alicia Gauvin, who was an CSPH intern who put a lot of work into helping me produce that website and then manage communication and outreach afterwards. And Danny Zients, who's an MPH student at McGill, and she was my intern for the summer and did a lot of work with me on crunching data. And she did a lot of writing as well. So moving on to the next slide. There is a picture of Megan up in front of a group talking about Tennessee. Next slide, please. So going over the results quickly, if you want to, we'll try to move through them so that we don't run out of time for the really good and meaty stuff if you want to advance it. So here's a picture, screenshot of our website and the report. You can go ahead to the next one. Brief review. So the 2012 rankings included the 50 U.S. states and District of Columbia. They were ranked 1 as best or highest to 51, lowest or worst, by the composite score. That is the score produced by the composite index. The composite includes 26 individual indicators of sexual health. It was constructed, the data sources were only existing data that was publicly available. There was no original analyses or privileged access to data or primary data collection. So used only what is already out there. And for those of you who like equations, that's the equation for the composite score. if you want to move along. So here are the 2012 top 10 rankings. Vermont, number 1. And you can go on to the next slide. Mississippi, number 51. I don't want to spend a lot of time talking about each state here because you can really delve into this on the Sexual Health Rankings website. The tables are interactive. You can click on a state to see its scores and actual data values for each indicator. You can click on an indicator to see how all the states stacked up on that indicator. So that's fun to do if you like to do that kind of thing. Next slide, please. And here's a graphic visualization of the rankings with nice cool blue representing the highest ranked states and angry red or caution maybe, danger red representing the lowest ranked states. Next slide. So now we'll talk about what all went into this and what the continuing issues and challenges are, and the process by which we're continuing to build. If you can advance it. So what is sexual health? This whole project is based on the World Health Organization's definition of sexual health. I'm not going to read this slide aloud to you, but suffice to say, it is a holistic, in the sense of all-inclusive, concept of sexual health, not just the absence or presence of disease, but a whole concept involving one's sexual experiences, not in terms of just experiencing sexual pleasure, but also not being discriminated against or being a victim of violence related to sexuality, and it includes the recognition of the right of people's sexual rights. So these are nested terms that the WHO put into their definition to make, to pack as much into as few words as possible, even though it's still a lot of words. So I'll show you those. There are sub-definitions if you want to move to the next slide. So what is sexuality? There's a definition of what is sexuality. What does that include? Everything. If you want me to go back to this at any point, we can. I just don't like to read slides. So next one, please. And also sexual rights. What are sexual rights? There's a consensus definition on sexual rights. And I think it's important to say that this World Health Organization definition was not produced in a vacuum or arbitrarily. It is a product of a very large technical consultation of international experts from many disciplines that hashed this out. And the actual publication date on it is 2006. These meetings happened earlier in the 2000s. But it was important for me in using this as the foundation for what I was trying to do with sexual health rankings, and am trying to do with sexual health rankings, to have something that to hang on to that is an accepted and very carefully considered definition. So it's not just me saying, well, this is what I think sexual health is. It's building on this very important work that the WHO did. So next slide, please. For the purpose of constructing the composite, it was really necessary to try to distill all of those words to elements, which, and even this is sort of shorthand for longer sentences. There are 5 elements of sexual health in that definition. If you pull them out of the syntax, there is one's ability to have control over one's sexual behavior and experiences. So we always, in shorthand, we'll say autonomy. The ability to choose if and when to procreate, reproductive choice, freedom from discrimination and violence, freedom from discrimination and violence related to sexuality, to sexual orientation, to gender identity, to sexual expression. The experience, one's experience of sexual pleasure and satisfaction with one's sexual experience. We'll say a lot more of that. We'll talk a lot more about that coming up. And then, of course, even though the definition states that it's not just the absence of disease, dysfunction, or infirmity, those things still are part of it. We're not taking away STDs, the one's freedom from having sexual problems, diseases, is also part of sexual health. So those are the 5 elements. If you want to move to the next slide. To the next slide. So, what is, I've used the term composite indicator a couple of times. I say this is a composite index. I want to talk about what composite indicators are, and what with the history, what kind of methodology employing here. So, let's advance the slide. So what is a composite indicator? A composite indicator or index, the terms are used basically interchangeably. A composite indicator measures a multidimensional concept. It's something that cannot be captured by a single indicator. But it's something that something real, just not something small, or that could be described succinctly and adequately by one kind of measure. And it's a mathematical system of combining individual indicators that measure different points or aspects of this big concept that you're trying to get a handle on, into a single index, and therefore producing a single statistic, a single measure. And it's based on an underlying framework, a theoretical framework of that's not arbitrary, of what that a definition really of what that concept is. So if you want to advance it, please. The methodology that sexual health rankings builds on, a lot of this work comes from economics, and it comes from Europe. So the Joint Research Center of the European Commission does a lot of work on composite indicators, and that's also related to the OECD, also a European agency. And in the health space, really the example that I looked to and took examples really that I took inspiration from were America's health rankings and county health rankings, both of which try to do the same thing and really transfer this idea of composite indicators to population health. And they were really my inspiration for attempting to build this project in the first place, because I looked at them and I thought, wouldn't it be something? I wonder if there's one for sexual health, and I couldn't find one, so I had to do it. Next slide, please. So pros and cons. Composite indicators are not perfect. I'm not proselytizing about composite indicators as being the end-all, be-all. I mean, they are very interesting and really useful. Building a composite indicator is a way of summarizing and getting a grasp on and understanding a very complex, multidimensional concept. It also, I'm sure there are so many different indicators are related to sexual health that are indicators of sexual health, to try to keep track of them all and figure out how they're related and see trends is really difficult. So it helps to interpret all these data that are out there, and it also enables comparison and ranking, which is in and of itself important to those entities. I say entities. It could be countries. It could be states. It could be counties. It could be metro areas. It's important to them to see where how they stack up, and it also is something that people really are interested in. People get interested in rankings, and it attracts attention, and it's a way of starting a conversation and putting messages out as well. So the cons are that they're not perfect representations of reality, and they could be, if taken way too seriously, send misleading and simplistic messages and lead to policy mistakes or missteps, or go off in a wrong direction. We always have to acknowledge that building one involves the judgment on the part of the builder, and there are lots of different variables and decisions that are made that can be argued with. So that's why I'm talking today, and why I continue to reach out and engage stakeholders, is that transparency is really important. It cannot be a black box. Nobody will accept the outcome of a black box, and it's really important for stakeholders to accept it. Otherwise, it's meaningless. So, next slide. So I'm going to talk to you, speaking of transparency, about the process and some of the questions, and what I'm doing now and what I hope to do, and some of those judgments and decisions. Next slide. So here is a diagram of the process. And we're going to go through each step and talk about some things related to that. This is kind of your key slide. We'll start with the framework. To advance. Oh, yes, I forgot about the slide. Sorry. So the 2012, the first edition of Sexual Health Rankings, really focused on the framework, developing the framework, looking at the indicators, and figuring out a weighting system and trying to deal with that. The multivariate analysis part is not as complete and fleshed out. And these are things. The shaded things here are things that I'm working on now. Looking at the data structure, testing the model using uncertainty and sensitivity analysis to see if it's a robust model, and then taking that statistic, taking that composite indicator, and then doing things with it. The rankings are good. They're a product of this as well, but there's also you come out on the other end with a statistic that you can then use to explore other things and continue investigating. So next slide, please. The framework. So that's the definition. And it's really important, and I'll say this when I get to the next slide again, but to define the concept, what are you talking about, and then break it down even further. What kind of indicators measure that? Broadly categorize them, and figure out what kinds of things you're going to go and look for when you go to choose the indicators that go into the composite. So next slide, please. So here's the Sexual Health Rankings framework. It's based on the World Health Organization definition, broke it down into those elements, and then the categories of indicators. These are things, I'll talk a bit more about this coming up, but broadly categorized as outcomes, measures of health status and impact, and factors or determinants of health. And then these subcategories of that, boxes within boxes, these are also drawing on World Health Organization work on on categories and kinds of indicators of sexual health. So laws, policies, things pertaining to human rights, education, social things, society and culture. I can't escape how that sounds like a trivial pursuit category, but economics and then the health system. So, next slide, please. Here is a breakdown, the table of indicators, the summary table, outcomes, then domains within outcomes, the indicators, and then factors, and then there are those categories under factors. And I would love to park right here and just talk about all of these right now, but we can come back to it, and I'll answer questions about it because we have to move forward. And these, again, of course, you can explore at your leisure online. So it's really important super important that the framework informs the indicator selection and not vice versa. You're not defining the concept based on what data are available. You're defining the concept and then going and looking for indicators that measure that. So it should be systematic. There should be criteria for selecting the indicators. Are they relevant to the concept? Are they available? I mean, are they not only available, can you get them, but when are they published? How regularly? Will they be published again in the future? Are you sure? And are they good quality data? So next slide. Relevance, and I think we'll come back to this if we have more questions. But really, looking at it's kind of a way of matching the indicator. Does it relate to this element of sexual health? Does it relate to that one? And not just arbitrarily, but really looking at evidence and finding a foundation for arguing that this indicator is related to this this aspect, this element of sexual health. Next slide. And here is how the sort of domino-looking thing, that is how in the 2012 edition they are matched up. And this is based on literature review and careful consideration. If there's a bullet there, it's because there's evidence that these things are relevant and related to. They measure that element of sexual health. So continue to the next slide, please. Availability, like I said, the data for the purpose of this project, the data needed to be available. State level data needed to be reported, and like I said, published reports, public data sets, no primary data collection. I covered that earlier. Next slide, please. Data quality. Are they real data? I mean, are professional, reputable organizations collecting this and reporting it? The time frame is really one of the main concerns. We know that we never really have the exact data that we want. We don't have all of it. We don't have it as often as we'd like. There's a lag. So there had to be some considerations and given to how far back are you willing to go if you're saying this is the 2012 edition of Sexual Health Rankings. Not all of the data are going to be from 2012 because we don't have same year data or even annual data for everything that we're interested in. So for the purposes of this, for the 2012 edition, set the cutoff at 2008, and considering whether or not it would be really useful if these data aren't going to be updated or for a long time, it may not be useful to include if it's too static. And then of course the concern, are there issues? What are they that could affect the comparisons between, or comparability between states? So next slide. And here are all the indicators, again with sources this time and years, editions of the data. A lot of course, a lot of CDC data, and then for these for the laws and policies pieces, used the almost, sort of the published digests put out by the Human Rights Campaign and the Guttmacher Institute for those indicators, for a lot of indicators, as well as not just the policy and law things, and census data. So it's these are the sources, and those are the freshness of the data for the 2012 edition. Next slide. So yes, it is. There are challenges. One of the results of findings of this is what can't you find? What data aren't there? Because that tells us something about, because we're working forward and not backward. We have a framework, and we have a concept, a definition of sexual health, and there are holes. And so there are things that we know that we're not getting the full picture. So those broadly are positive, wellness-focused measures of sexual health. And we're going to talk about this idea of measuring sexual pleasure, sexual satisfaction next. So next slide. So measuring sexual pleasure, at the population level, is a really interesting question and challenge. How do you measure sexual health? How do you measure sexual pleasure at the population level? If you were to do, or in an individual sort of clinical type of context, it's different from thinking about population measures, because some of the questions are what is optimum, what is suboptimal, what is not enough, too much. Is the quantity of pleasure that you have important, or the frequency with which you have it, or the quality of the sexual pleasure you have? And I think that measuring pleasure per se is really tricky, because it involves value judgments. In order to establish a measure, you have to establish benchmarks, and which way does it go? I mean, and to whom? So if you'll advance the slide, this is why I think it's more appropriate or useful, say, to try to measure sexual satisfaction. And that's the degree to which someone is satisfied, people are satisfied with the sexual pleasure they have. It's value neutral, because it is so variable across individuals. I mean, one person may be very satisfied with X amount of sexual pleasure, or one person that would be completely unsatisfactory to someone else. One person may put a very high premium on, orgasmic capacity or frequency, and to another it may not be what's really important and satisfying about sex. In terms of measuring sexual satisfaction, it's more is better. The more satisfied you are, I could argue, is unequivocally better than being less satisfied. Next slide. In Sexual Health Rankings 2012, because there are not direct measures of sexual satisfaction available, what I tried to do was find proxy variables. And the OECD, Organization for Economic Cooperation and Development, who publishes this, a lot of work on composite indicators, gives permission to do that with caution. So the proxy indicators that I came up with are self-reported health status, good or better in the positive direction, and relationship status, married or partnered, basically being in a relationship. So next slide. These are data that are available. They are measures on the behavioral risk factor surveillance surveys. So self-reported health status. There are a number. There's a good body of evidence, and I wish I hadn't abbreviated these because I'm just gonna stumble all over the initialisms if I try. All of these references are in the report and on the website. A number of large population-based representative surveys show that a positive association between sexual satisfaction and better, greater sexual satisfaction and better self-reported health status. I know that one. The National Health and Social Life Survey back in '92 found that fair to poor health was a predictor of sexual dysfunction. So making the sort of the leap that sexual dysfunction also decreases sexual satisfaction. There also is there's a positive association with the frequency of penile vaginal intercourse. That's what is more measured than it's not everybody has penile vaginal intercourse, but that's a lot of people do, and also then again, more frequent sexual intercourse is also associated with greater sexual satisfaction. But all of these studies that I looked at primarily concerned midlife and older adults. So you can argue about whether they're can be generalizable to younger people. Next slide, please. Relationship status. So, whether somebody is in a relationship defined as either a member of an unmarried couple or more generally in a relationship, not single, not just dating, not widowed or divorced, with somebody. Numerous studies show that there's positive association with sexual satisfaction, and again with intercourse, not only vaginal but also oral and anal. So, next slide. So that was, we'll just say plainly, that is the best could do in the absence of a direct measure of sexual satisfaction. Those proxy measures have not been validated. This was not, a meta-analysis. It was really, a best try. And I think, worth looking into, worth considering. I think that they make sense, but I think that that there really ought to be those really ought to be validated, and I also think that it would be good to try to find other and continue research. I'd like to see more research on correlates of sexual satisfaction in populations. So a direct measure would be something that whether a scale on a survey that really is not just about one type of thing, something that really is about physical, emotional, and within the context of a relationship, in relation to oneself, attitudes and behavior. So I think that I wouldn't feel comfortable just going and designing that survey. I think that it would be really useful to have a collaborative effort geared toward developing a scale or survey to try to measure that directly if possible. But then again, what is really feasible? Would it really be better to directly measure sexual satisfaction in the population? Is that actually feasible, or would it be better to focus on trying to find a valid proxy measure, something that is already measured that can be used for the composite? These are questions, and I want you I bring them up to consider, and something that I'm thinking a lot about. Next slide, please. I also have a wish list of wellness-focused, wellness-oriented indicators of sexual health. Some of them are not really, completely foreign to public health. I think that we focus a lot on teen births. It would be really great, I think, to have, as part of our routine public health surveillance, a measure of intended pregnancies and births, recognizing that for many people, having a baby is a positive outcome of sex. Condom use, again, it would be very good to have that in hand at the state level every year to compare states, because condom use is, for STI prevention, as safer sex and as a method of birth control, is associated with self-efficacy, sexual self-efficacy. It has a lot of positive things that go along with it. To know more about other contraceptive use, to be able to measure knowledge and attitudes about sexuality, to know what people actually know, and again, because the frequency of partner sex and of masturbation. There's I mentioned in my last talk, Eli Coleman and I believe Walter Bochting published a book called Masturbation as a Means of Achieving Sexual Health. And then some other things to consider, because use of sex toys, use of sexual lubricants. This is, I'll be sending this to Santa Claus this year. Next slide, please. And then in terms of the bad outcomes, what is included in the 2012 rankings is the FBI's Uniform Crime Reports statistics on forcible rape. And I had a question last time that what that was about. Actually, the old definition of forcible rape was the carnal knowledge of a woman by a man. So it only concerned men raping women with penetration. So there is a new, the Justice Department has adopted a new definition for collecting forcible rape. Well, they don't even call it forcible rape anymore, for sexual assault, sexual abuse data, and those I don't remember exactly when the data collected under that new scheme are going to start coming out. I believe that, and I could be wrong, but I believe that this year, 2013 was the first year that those data were collected with that new definition. So that might improve that statistic. Next slide, please. Oh, yes, and then the national Intimate Partner and Sexual Violence Survey carries a big warning label that says, "Do not compare states." So I said, okay, I won't. Next slide, please. Then, of course, and I wanted to get to a question that I from last time that I don't think I really answered completely adequately about how the rankings can be used at the local level. I was thinking local like town, but by states, and I think that one of the things that is useful is looking at the gaps and saying, for example, the YRBS, not all states collect data, include questions related to sex. And those would be terrific statistics to include, but they can't be because they're not available for all the states. So I know that from when I presented at the YTH Live conference out in San Francisco earlier this year, that there are organizations that have gone and lobbied their state legislatures to include sex questions on the YRBS. So that I wanted to bring that up because it was something I wanted to say in response to a question I got last time that I didn't say. So that's one example of state-level indicator that could use use advocacy, action, so a place to focus. So next slide. Looking at the time, I'm going to move along, and I got to this one last time, and I don't, it's hard to gauge how interested in this analysis everyone is. So I'm gonna charge through it and try not to not have any time for questions again. So next slide, please. Multivariate. So how, really looking at the structure of the data. In what I've been working on presently is using principal component analysis to examine, are these data, is this multi-dimensional concept that I think I'm measuring actually multidimensional, or are all the data completely uncorrelated with one another, or all correlated with one another? You might as well just pick one and be done. So PCA, without getting too technical, is a way of looking at how the variables change in relation to each other and how they're associated. It can be used to cull the list of indicators and focus on those that are actually responsible for the most variance in the data set that are actually really driving it, and as a weighting tool. So next slide, please. And I'm going to show you these charts. This is so looking at the components. Component 1 explains roughly 20% of the variance in the data set. Component 2, a little less, less, 16.5 roughly, and on down. So these are groups. The components are groups of indicators that move in relation to each other, that are not related to other groups. So next slide. And this is just showing how component 1 accounts for the most variation, and then if you go on to the next slide again, and then on down. So it gives you a sense of seeing your multidimensional concept not as just a stack or list of indicators, but really as something that moves, that is more of like a constellation of data. Next slide. And I'm really afraid of not leaving time for questions, so I'm going to skip getting into this one. I can answer questions more about that at a later time. So here, component 1, the things that are highlighted here, these are the factors. These are the indicators that are most highly correlated with that component, and so on. So it's they can be used to kind of see patterns and see what things are related to one another, and how so. So next slide. And again, I mentioned using that as a way of weighting. Weighting is incredibly important, and it's also very messy, and there's no one right way to do it. And you can get different results by weighting things differently. So you have to make a choice, though. You can't not weight them, because if you choose not to weight, then you're actually choosing equal weighting. So if you want to go ahead to the next slide. The system used in the 2012 rankings is really designed to try to minimize the overrepresentation of the disease, STD, and so that it's not actually turns out to be just an index of the things that are already measured, but to try to ensure that each element of sexual health is equally weighted. So each element gets equal weighting, and then the actual indicators are weighted according to their relationship to that element. Next slide. And those are the weights. We're going to keep powering through, so we have time for questions. So like I said, if you do nothing, you're actually choosing equal weights. You're saying that all of the indicators are equally important. Again, I mentioned that there's a option of deriving weights through principal component analysis, which does not weight them by their theoretical importance, but rather by as a way of eliminating overlap in where indicators are correlated with one another. And then the approach that I have not tried, which I would really very much like to, is a participatory approach, to have experts or some stakeholders in the outcome of the rankings participate in the weighting, either by the budget allocation process or analytic hierarchy process, which some of you public health folks may have used in various types of group processes. And so basically getting a group of people with a stake in it who know something about it to say how they would weight it, and then weighting it based on the outcome of that process. So it gives everybody a stake, and it's a different, it's really no more or less valid or correct than the other ways, but I think it's if possible, it helps increase buy-in and continue that whole discussion thing, which is so important. Next slide, please. So the other thing that's going on currently is doing the uncertainty and sensitivity analysis. Really, and boiled down simply, that's saying it's a way of measuring what happens if you make this assumption. How does that affect the end result, as opposed to if you make that assumption. And those are the uncertainties, the assumptions that you make. And then the sensitivity analysis is how those, which sources, looks at which sources of uncertainty have the greatest effect on the overall composite. So, next slide. I said that in so many words. Some of the important sources of uncertainty are which indicators you choose, how you mathematically standardize, normalize the data, aggregate them, and then of course weighting, which choice you make. Next slide. And here's a little example of one uncertainty analysis. Done this was just knocking out one indicator at a time. The bars show the highest score and the lowest score, and then the median score based on removing indicators from the composite. And I find this encouraging because the trend stays a trend. You don't have crazy ups and downs, which would be worrisome, because then it would show you that, well, if you choose not to include this indicator, then Maryland is suddenly number 1, and Vermont is number 33. That's a good sign. So next slide, please. Again, transparency in the end result. The whole purpose of doing sensitivity analysis is, I borrowed this chart, this figure. You can actually see which source of uncertainty has the most effect for which, in this case, country you're measuring. So it helps those that are being measured or have a stake in the measurement to understand what's affecting their result. Next slide. And the sensitivity analysis is a complicated thing. It's not a quick back of the napkin calculation, and we're working on it. It takes some time, but we're doing it. Next slide, please. So yeah, and in closing, I mentioned really, what do you do with this now? I think that if in the end you come up with a good composite, then you have something that you didn't have before that you can then use and say, investigate, study relationships between the composite and other variables of interest. And one potential application is, maybe to track, performance or to evaluate outcomes or effects of decisions and to then begin to see if really not just on this one thing, but on the whole thing, something has an effect or a significant relationship. So I think, is that it? Yes. And now I will be happy to answer your questions.
Great. Thank you, Martin. We've had a few questions through the webinar. If you have questions, please put them in the chat function. And if we aren't able to get to your question, we're going to combine a few unanswered questions from last webinar with any questions we don't get a chance to deal with today, and put them hopefully in a FAQ with Martin's help.
Yeah.
So I think one of the questions we had is could you say a little bit more about the measure of sexual satisfaction, and why is it associated with being in a couple?
Yeah, I mean, hello? Hello?
Yes, still there.
Oh, okay. I didn't. There was a click. I don't know if I got cut off. Yeah. I think the direction of that relationship has not been established. Actually, I think that's one of the most interesting things about it. Based on the evidence that I looked at, there, and again, I can't readily talk about the magnitude of the association, but it's just a consistent finding that being partnered is people who are in a relationship, who are partnered, tend to report that they are more sexually satisfied than people who are not. I don't think that there's any kind of consensus about the directionality of that. Does the relationship which comes first? Which is sexual satisfaction contributing to the relationship, or is it being in a relationship make you more satisfied with your sexual experience? I think that is something that I think needs to be continue to be investigated. But I mean, just kind of speaking offhand and personally, and not like from an authoritative position. I think that it intuitively makes sense, but I couldn't begin to guess which direction, whether one is if being in a relationship creates satisfaction, or if it's the other way around. So
great. And then kind of going off that as well, that we had a question. The question was, can partner concurrency affect sexual health?
Yeah. That's a terrific question because the measures as they exist do not consider, they assume that if you're in a relationship, if you're partnered, you are partnered with one other person, and don't account for concurrent. Is that what you were asking, or am I misunderstanding the question?
That was really all that the questioner listed, but I think that is accurate.
Okay, because I could be being really boneheaded and not understanding concurrency. So forgive me if I am.
The answer, the questioner just wrote in the chat function and said yes, so I think that was the correct question.
Okay.
We got a question on this webinar similar to the last one about data on reported sexual abuse rates. If you looked at that, or any public data on sexual abuse rates, and also the number of adults with diagnosed sexual dysfunction.
Right. Yeah. The data on sexual dysfunction, they tend to be, clinical data and not really population surveys, looking at the prevalence of sexual dysfunction in the population, but really looking, examining clinical data and it tends to be more clinically focused, I guess I'd say. But there is, it's not to say that no research has looked at, correlates of sexual dysfunction or relationship of sexual dysfunction to, but the actual prevalence in the population, like the general population, it's not something that's like routinely part of public health surveillance. But there are certainly that it's a component. It has been a component of big surveys, and it's just not something that is regularly measured, like things like teen births, say, or other things that are just kind of regular and routine, which is just the state of things, I would say. And correct, tell me if I'm wrong about that. That's how I see it.
And what about any available data on reported sexual abuse rates?
Yeah, so I mentioned the National Intimate Partner and Sexual Violence Survey is a big CDC project that right now I think the sample sizes, there's concern about comparing states with one another because statistically the data set is not big enough that all of the comparisons would be significant. But that does look at not just crimes reported, but it's a survey. Self-reported. Have you experienced this? And not just reporting an assault to the police or looking at crime records, but histories of and experience of sexual violence, intimate partner violence, and things that don't abuse and victimization, sort of outside of the court, what's reported.
Okay, great.
And potentially, and I don't want to speak for CDC, but my understanding is that it may become, state comparisons may be possible as the system expands and the data start to there's more to look at. So
great. And we had one webinar attendee who said he's interested in educating and planning with an HIV planning group that he is with locally, and he would like to move them to a more sexual health focus and philosophy. And so he was wondering if it's possible to use the slides with acknowledging you in a training that he's doing.
Certainly. Just if he wouldn't mind just letting me know about it, but certainly, yes. With
Great,
attribution, everything's it's fine to use.
Great. And I should let folks know that I did advance the slide, and on your screen right now is Martin's contact information, which will also be part of the slides that we send to you afterwards.
Yep.
So you think we might have time for one more question? They said one final question is, was there ever any consideration of social desirability scale as a limitation?
I'm going to say that one's went over my head. I'm not totally up on all of the scales.
Okay.
So it rings a bell, but I'm just going to say I don't know.
Okay. Okay. No problem. No problem. And then want to let folks know and remind folks, of course, that this webinar was recorded. So as I said, NCSD will be sending out the full recording from this webinar as well as the slides to all of the registrants today. So we really thank you again for Martin for doing a redo and a round 2 of this webinar, since we've had so many people interested in this topic. And I think with that we might also just thank the participants for joining us today, and look for an email from me with the slides and the recording.
Yep, and please do feel free to get in touch, and if share or continue to ask questions. And thank you all for staying on the phone. Whether you're on speakerphone or if your ears are red at this point, I appreciate it.
Great. Thank you so much, Martin.
Okay.
And with that, thank you everyone. Have a good day.
Bye-bye.
Bye-bye.
Thank you. Please stand by.